Okay.
So welcome back for round two. We have three new funders to give their perspectives on the proposals that they looked at, and I'll introduce them first. Arlene Bierman is at ARC, the Agency for Healthcare Research and Quality, where she leads the work for the Center for Evidence and Practice Improvement, which includes 5 divisions, including the U.S. Preventive Services Task Force and some others. Dr. Bierman is a general internist and a geriatrician. Then Don Schwarz is Senior Vice President at the Robert Wood Johnson Foundation and is responsible for a team that is working on the culture of health work that RWJ has been embarked on for a while. Don was Deputy Mayor and Health Commissioner of Philadelphia, and he was also a Professor of Pediatrics at the University of Pennsylvania and the Children's Hospital of Philadelphia. And finally, Daniel Yang is a Program Officer at the Gordon and Betty Moore Foundation, where he established the Diagnostic Excellence Institute. He is also a practicing hospitalist. So, Arlene, I'm going to start with you. You had a chance to look at the work related to algorithmic bias, in particular the ways in which we allocate dollars, federal dollars being one example. The patient safety and workforce safety, which introduced, I think, the interesting notion of inequity as a harm that should be integrated into our safety approaches. And then a really interesting program looking at the transition of incarcerated individuals back into the community, something we're actually seeing at rather a large scale in California right now. So I think this is a very important area. All of these proposals had, I think, a theme related to measurement and data, something with which you are quite familiar. So Arlene, love to hear your thoughts about what impressed you about these proposals and what you would see as promising areas to move forward.
Yeah, so when I first looked at the topics, I said, wow, these are 3 really diverse topics. And it was amazing how well they came together. For example, in the breakout group on algorithms, we were just talking about community health workers that Emily Wang is using in her incarceration project, and clearly safety, including equity as a dimension of safety. So when I was looking at these last night, I decided to kind of think about common themes in terms of research and advancing the science. And I just want to start with a little story, because earlier in my career, I went back to my old neighborhood in Queens, and I practiced at Elmhurst Hospital, which has been tragically impacted by COVID. And I directed the Department of Ambulatory Care there and the Primary Care Internal Medicine Residency Program. And my first grant I ever got was the United Hospital Fund to partner with our community and build those relationships. So people have been trying to do this for decades, and I'm hoping this is really the opportunity to move this forward. But I just want to tell one anecdote, because on one of our first meetings with community organizations, we were exploring what were the barriers to our services, how could we facilitate access? And people said, well, when people come to your clinic, they're asked for their green cards and they don't want to see the doctor because our clinic cards were plastic and they were green. So we changed them to gold so that people could be asked for their gold cards. So just how sometimes simple changes, listening to the community. And I was so glad, I've been so impressed with all the presentations during this forum. The little changes can actually make a big difference sometimes. We don't have to always boil the ocean. But then thinking about how are we gonna, advance change, I was thinking about 4 things. We really need culture change. We need change in the culture about the way we deliver care, the way we interact with patients, the way we interact with communities, what our values are, what we care about in terms of outcomes. And one of the things at ARC we did was develop the care and learn model, because we felt that there's so much great work going on in terms of the data and algorithms and generating evidence. And there's also a lot of great work going on in terms of interpersonal care and working with communities, and they're often separate. And I think this group of 3 proposals really shows how we can bring these together, the caring and learning, and really advance health. The other thing I was thinking about was sustainability. As we design these solutions to really, we want to re-engineer the system, and we don't want to just invest on something that's really cool and we have added resources, but actually how do we transform systems so that we have sustainable change in what we do? And the other thing is that we have a lot of evidence, we need more evidence and we gather evidence about what works clinically, but that we really have a huge opportunity to get the evidence on what works to transform care just as much. And also the evidence for how do we foster equity, and then how do we scale and spread these solutions across the health system. And then finally, sort of, given the 21 topics that were raised, they're also diverse. But I think that we can really align our work and see ourselves as part of a community and make sure that our solutions, the sum is greater than the whole of the parts. I could say at ARC, all of these, solutions really align well with work that we're funding and our priorities. We include equity really as a cost-cutting theme in all of our funding announcements, and really love to get applications that include that. And we know that as we improve quality and safety, we could actually exacerbate inequities unless we explicitly pay attention to that. So we really, would love to support work that advances these solutions. And I just, for the algorithms, Ziad talked about, really building the data and trust to be able to get that data and increasing our capacity. Tejal to really make safety, equity part of safety work. And then in terms of incarceration is like really thinking about who's left out of our systems and who are we not serving well. So I'm just gonna stop there. Thank you.
Thanks, Arlene. So Dawn, the proposals that you looked at included looking at ways to advance the work in social determinants of health. Some of the work in really leveraging public health for focusing on the health of communities, a new way of using community health needs assessments, and bringing up advocacy opportunities. The healthcare for the homeless, alternative care sites for the homeless, I think one of the really striking videos that we saw ahead of the forum, and then reframing the discussion around gun violence. So all of these proposals, I think, had in common bringing the public health system and a public health mentality into our discussions, and then thinking about social determinants, thinking outside of the healthcare services system into the critical components that drive forward the health of the population. So Dawn, some reflections and thoughts about the set of proposals you looked at.
And I should start by saying congratulations to everybody who was both brave enough and wise enough.
Don, you need to put up, we can't hear you well, Don.
Huh. Is that better?
That's much better.
Yeah.
Okay, thank you. I just want to say congratulations to the folks who brought their ideas forward and to those who contributed. It was a wonderful set of conversations that I was in, and the documents that the work that I got to review, pretty impressive. I was struck by the tension, which is a tension in public health, not so much in healthcare at times, but the tension between local innovation, local ideas, local need, and national action, which is a tension between doing programmatic work often locally and doing policy work at the national level. And it came through in all of the 4 groups that I read through. And I think in each case, there was a different approach using a big idea to how to address that tension. So for instance, in Kirsten's work related to the social determinants of health and healthcare institutions, the big idea is to provide a national roadmap for local efforts for healthcare institutions to address social determinants of health. But it's clear that the work to do that needs to be inspired by, needs to take count of local context, and needs to also be combined with both policy change and headset change at a national level. And the nice thing about philanthropy and funding in particular is there are local funders and national funders who have different approaches and different abilities to bring partners together and help bridge that tension. Mary Ann's work on public health, which is the session I was just in, and how COVID is highlighting the need to learn nationally from this moment and the need to advocate around funding for public health in particular, has a big idea about bringing public health national organizations and local organizations together to come to an agreement on how public health and healthcare should align. And the one piece that I would highlight is that there should be a common voice and there should be a common mission, as the group discussed, but it's been hard to get to. And conveners, maybe philanthropic conveners, maybe government conveners, maybe others, are needed to bring together not just the traditional partners, but those like the Heart Association and the Lung Association and the Cancer Society, who have one hand in public health and one hand in healthcare and both feet squarely planted within communities. Their memberships are huge, their reach is tremendous, and their ability to bring people together to understand and move forward an agenda is real. Megan's work on gun violence and bringing gun advocates and gun opponents together for local conversations on harm reduction and firearm injury prevention is a really big idea. That needs not only strong stories, but strong evidence and experience. As she said, it's early days for an opportunity where I think local philanthropy and local groups are going to be critical, and the national conversation will come. But starting locally to test out new ways of approaching this, really important. I wonder whether funding this work could even be done locally, either through crowdsourcing or a group like IOBY, I-O-B-Y, which is an interesting hybrid of leadership development and crowdsourcing that could be a partner for the work. And finally, Jesse's group is doing amazing work, as we saw in the video, with homelessness and trying to navigate through the nightmare of homeless folks trying to remain healthy and safe at the time of this epidemic. The big idea is that we have an urgent need for safe isolation for the homeless during COVID, with incredible work that's been done in Boston that looks at the uniqueness of a local context and highlights the utility of national packaging of best practices in real time, so that every community doesn't have to figure out all of it together, but can benefit from the experience of other communities. That work is, I think, a beautiful example of how we can tie local, state, and national audiences and work together in order to benefit everybody, but particularly real people with real needs today, tomorrow, and into the near future. So thank you all for all the great work on this.
Thanks, Don. Daniel took a look at the proposals related to, while it was labeled diagnostic bias, I think what's interesting is it was the idea of equity rapid response teams really mobilizing resources out into the community. A really proactive design around telemedicine and digital health. And then the challenges that we see every day if you watch the news on misinformation and health literacy and how we can leverage public health campaigns. So I think an interesting set of proposals, and Daniel, let us know some of your thoughts about them.
Have we unmuted Daniel?
All right, there I am. Hi, thank you.
Okay.
Just to, yeah, I have to confess that yesterday I had about 5 mini heart attacks every time I heard my name, thinking that someone was calling me. Then I realized in the forum I'm the other Daniel. I should also say that, as a disclosure, that the Diagnostic Bias group, led by Gurpreet Dhaliwal, I was fortunate enough to train under Gurpreet, and it wasn't too long ago that he was my attending giving me feedback on something like my differential for hyponatremia. So I'm pleased, and it's a unique opportunity to return the favor. So, in terms of the topic of diagnostic bias, their big idea was around these rapid response teams, which would essentially, I understood it to be a multi-stakeholder group, a committee that would help allocate limited diagnostic resources with a health equity lens, looking at communities that are underrepresented when it comes to both outcomes as well as testing access. And in the conversation yesterday, someone made the astute comparison between COVID testing and HIV testing early in the epidemic. And I think when we make that comparison, obviously they're both very consequential diagnoses. There are a lot of differences between them, but we also know that HIV testing in itself is necessary but insufficient. So even if we were to narrow the gap of diagnostic testing access, we need to couple it with a suite of downstream interventions. And so I think, thinking about what those interventions are, even if we were to improve access to testing, is that enough? Is that sufficient to improve the disparities in outcomes we're seeing in these populations? The second point of feedback is really around timeline to impact. Normally you would fund a pilot project. You would meticulously design it, you'd find a city to implement it in, you would then collect the data, you'd analyze it, you'd publish it, and then you'd kind of hit the road and try to disseminate it. With COVID, that timeline of, if you're lucky, that might happen in 2 to 3 years, it just doesn't work. And so even a delay of 3 to 6 months, the epidemic changes. So how do we, as funders, fund work that is important, but also impactful in a timeline that matters? And so, I would take a step back. Instead of thinking about a pilot project with one particular city, maybe the concept might be partnering with 20 different cities. Maybe you can build a coalition of 20 cities that are interested in this concept of a rapid response team. There's a general broad outline of what that might look like. Each city can interpret it in their own ways and implement it. And what the funder is funding is a learning collaborative. What they're supporting is a infrastructure for learning. So that might be identifying what a shared metric of success is. It might be reporting on the data. It might be calls between the different cities in terms of identifying shared barriers, peer mentorship. And I'm thinking kind of along the lines of the IHI Breakthrough Collaborative model. And maybe a dissemination strategy baked into this is not publication in a journal. Maybe it's committing, each city as a condition for participation is committing to mentor 2 or 3 other cities that are like them in standing up their own programs. On the topic of telemedicine and digital health, their big concept, particularly focused on Kaiser Permanente, is how do they move their care to 50% virtual care? And virtual care is including video conference calls, telephones, chats with physicians, emails, asynchronous calls, asynchronous communication, etc. And I'll say that first, the concept of virtual care to me implies some sort of judgment. I haven't been to the office at the foundation in 5 months, but I wouldn't call my work virtual work. I'm just doing work. And I live in the Bay Area, and I feel like one model that's been instructive of what the technology companies have gone through in the last 10 years is this movement from building applications that were originally designed for desktop computers and for web-based browsers. So think Google, or Facebook that you would use on the desktop, to mobile applications. And so all these technology companies have gone through a transition called a mobile-first focus on their design principle. And what that means is you're not just trying to take a web-based application and squeeze it into a smaller screen, just make the buttons smaller. You actually reconsider the primary use case for our application is this platform, which is a mobile phone. And you don't just think about the limitations, what that means, you actually think about the assets. So think about Google Maps, using Google Maps on a web, on your browser versus using Google Maps on your phone. It unleashes all of these new features that you can't use on a desktop computer. For example, crowdsourcing the best way to get from my house to work, or real-time feedback on an accident that happened, or a speed trap, for example. And I think when we think about virtual care, similarly, if we use that analogy, it's not just how do we virtualize in-person care and move it to a telephone or a video conference call. I think it's rethinking what default telemedicine first care even looks like. And it doesn't just mean how do we improve the virtual element, it means rethinking what the in-person component of that care is. So my question to, in that conversation is 50% virtual care, just taking 50% of the population and moving them into virtual care. Does it mean 50% of all care is virtual, which requires a reimagining of the 50% of non-virtual care to complement or augment it? You know, and then again, I think I appreciated Don Schwartz's comments about the tension between local and national policy. You know, wouldn't it be great if Kaiser Permanente were to partner with a lot of the other large integrated healthcare delivery systems, of which I know there are networks of research, and bring together you know, the social safety net hospitals and bring together their venture capital arms. You know, a lot of these technical barriers that are encountering are solvable. I know that a lot of these big healthcare systems have large venture capital arms that are trying to invest in improving care. You know, why not build a fund of $1 billion, let's say, or add another zero to it, which is just investing on improving the technology to serve virtual care. You know, why not partner with the large technology companies like Zoom or Google or Facebook that essentially do this day in and day out to meet some of these needs that are being identified in this natural experiment right now. You know, we heard a lot about issues for particular vulnerable populations not having access to broadband, you know, people difficulty with hearing, et cetera. These are all solvable problems. I think if we could identify what those shared problems are and partner with the people that know how to solve them, I do think that we can kind of get out of this adolescent phase of telemedicine and you know, and make it actually work for us.
Thanks, Daniel. So I think this idea of that kind of Don started with on this tension between local and national, and then this issue we always face with scaling. You know, I think the ideas that you're bringing up, Daniel, are really interesting. And I'm interested, Don, about just your reaction to kind of the way that Daniel suggested that we could sort of in some ways start large and find the balance between, you know, some kind of roadmap or infrastructure that's helpful, that is then adjustable local versus maybe starting the other way. Just welcome your thoughts about that, Don.
Yeah, I don't think there's one answer, and it's probably both and. So I'm not going to commit one way or the other. I think we're seeing that, if you will, top down and even grass tops down solutions often miss the mark or aren't perfect. And bottom up solutions, if we call it that, or community to national solutions, often have wisdom and provide ideas that are critical for shaping a national agenda, both in terms of messaging for that agenda, but also the parameters, what's really important in the moment.
Yeah. I think it struck me as similar to kind of when we look at complex interventions, how you figure out what's the essential component and what has to be adjustable to the circumstances. Arlene, I just wanted to pick up on something you said that I actually think we glossed over too quickly, and we don't have much time, but it's really about sustainability. So I think one of the challenges with big, bold ideas and with, you know, kind of breaking new ground is getting people all excited and then, you know, having the energy peter out after, you know, a year or two. Are there any insights you've had about ways to kind of ensure sustainability or to kind of enable sustainability?
Yeah, but I'm not sure we know how to ensure it. I think we can maybe increase the odds of it happening. And I think it's by really being explicit at the beginning, as that sustainability is one of the key aims. And as we design these things, really think about, you know, moving forward, are we designing something that will really change the way we do things so that it becomes sustainable rather than just doing add-ons?